examples. But without taking much of time, I'll just explain you how this session is organized. There will be an initial opening address by the founder and chancellor of NIMS University, Professor Dr. Balveer S. Thomo. Followed by that, there will be a distinguished address by Professor Ilona Kickbush. After that, we'll start a panel discussion. And the panel discussion is structured in a very different way. There are two important issues which we will raise and request each panel member to do a 2 to 3 minutes intervention. So basically, now it's 5:33. By 5:45 or 5:47, the initial opening and distinguished address should be complete. Then 15 minutes of first intervention and 15 minutes of next intervention. So you will get some time for Q&A of 5 to 7 minutes. Followed by that, we'll request Dr. Mona Dugal and Professor Balveer S. Thomo, the founder and chancellor of NIMS University, to stay here near the dais. So we'll have an MOU. Thank you so much. May I request founder and chancellor of NIMS University to give the opening address.
Good evening. Honorable dignitaries, distinguished guests, innovators, policymakers, healthcare leaders, and esteemed participants at the India AI Summit, welcome and good evening. It is both a privilege and responsibility to reflect on how artificial intelligence can become one of the most powerful equalizer and advancing health equity across our diversity and dynamic action. As we stand at the intersection of technology and humanity, AI offers us an unprecedented opportunity to bridge healthcare disparities, bringing predictive diagnostic and communities, enabling precision medicine for populations, strengthening disease surveillance and transforming public health agent delivery systems with speed, scale, and compensation. However, technology alone cannot solve inequity. It demands visionary leadership, ethical governance, interdisciplinary collaborations, and a shared commitment to the inclusive innovation. At NIMS University, we strongly believe that a meaningful progress emerges when diverse knowledge systems converge. Our integrated ecosystem spanning technology, artificial intelligence, medicine, public health, management, law, and social sciences creates a living laboratory where innovation is not only developed but responsibility transferred into a real-world system impact. We envision NIMS as a collaborative hub where researchers, startups, policymakers, clinicians, industry leaders co-create solutions that ensure AI remains equitable, accessible, and patient-centric. I warmly invite all distinguished delegates, thoughtful leaders, and change makers present here to collaborate, partners, and engage with the NIMS University as we collectively shape scalable, ethical, and sustainable AI-driven healthcare module. Together, let us ensure that the promise of AI does not remain a privilege for a few, but becomes a fundamental right for all that transform healthcare access, outcomes, and dignity for everybody, every individual, every society. Thank you very much.
Thank you, sir. May I request Professor Ilona, founder, Global Health Center, board member, NIMS Institute of Public Health and Governance, over to you.
Thank you very much. It's lovely to be here and being reminded of the fantastic regional summit that we had here about a year ago, and where I was also speaking in some of these halls. And I'd like to congratulate NIMS and the other two universities that supported it, Ashoka and Mahe, for that wonderful, successful event, which everyone still talks about, that was able to be here and has brought a tremendous shift also into how the World Health Summit, for where I am the co-chair of the council, is approaching regional summits. The issue here is, of course, absolutely critical to address, and actually one can just address it with 3 short words, and that is equity by design. And unless really, as we move forward with artificial intelligence for healthcare systems and for prevention and health promotion, unless we ensure that equity is part of the design of each and every one of the applications and the way we approach artificial intelligence, we will not be able to fulfill its promise. Actually, as has been discussed at some of the sessions here at this summit, we might even have the opposite effect. And this is also where research comes in, this is where the public-private cooperation comes in, because unless we have good data, unless we have reliable algorithms that do not consistently repeat the inequalities and the biases we have in our societies, we cannot expect that a new technology and a new tool will be able to help us overcome those problems and those biases. So we have to work together to clearly put this technological advance into a social and a political context. We need to be sure we train the people who train the algorithms, that they are aware of the social and political context, and that, as I said, they include equity by design. Because our health systems, as they are of course defined by unequal access, by very uneven capacity, by fragmented governance, and by incomplete data. And this is the challenge that we face, and that I hope very much that the panel takes up. It was very interesting also, just before I came here, I was in another session that was discussing with public health decision makers from various Indian states how they approach the introduction of artificial intelligence into their systems. There were public and private sector representatives there, and it was very clear that unless you have a clear idea about governance, about what you want to achieve, about the public health purpose and outcome that you want, that otherwise you will not achieve the results that we need in our societies. So I would like to very much underline also what is at the focus of the work of NIMS in public health, that there is a public purpose. And this public purpose for us who are in health is population health, is the reduction of health inequalities. We see health as a human right, and unless artificial intelligence helps us move that forward, it will not be fulfilling its purpose. Thank you.
Thank you, Professor. We recognize the presence of Professor Dr. Anurag Agarwal, Dean, Trivedi School of Biosciences, Ashoka University. Ashoka University was the co-host of the World Health Summit regional meeting, sir. So we have a very good memories of this place. And we also recognize the presence of Dr. Deepak, Director International, NIMS University, our faculty, Dr. Anupama, Mr. Anirudh, and Viola. We really thank Irene, the coordinator, for this session. So always thank people before you forget and get involved into the real business. So now I request Founder and Chancellor of NIMS University, sir, please occupy the chair. Ilona, please. Ms. Vinita, Dr. Mona, the girl. Abhimanyu, please. There's a request here that we should have a group photo now before we start a panel. That's part of the protocol. So let us take a group photo. Anurag sir, please. Let us stand together. Should we stand or sit? What's the protocol? Stand. Okay. Please occupy your seats. Good evening. I think everyone is here. Ms. Nande, who is the Chief of Health of UNICEF, there's a lot of traffic. She should be here anytime, but I think we should start. So as I mentioned, thank you for the opening remarks and the distinguished address. I think it was well within the time limits. I said 5:43, now it's 5:44. I think we should start the panel discussion. As I suggested, the first 15 minutes is a 2 to 3 minutes intervention by each of you, then followed by the second intervention. So I will start with Abhimanyu, with you. And this particular theme applies to all, so you can think about what should be the appropriate response as I come to the next person. Abhimanyu, this is the intervention is same across everyone. How can AI-driven health solutions be designed and deployed to advance health equity in communities facing digital divide? You could also highlight on the practice models or the best practice models. At UNDP, you have done excellent work in COVID, UVN. Over to you, Abhimanyu.
Thank you so much, Dr. Sanjay. My regards to extreme panelists and colleagues here. I think thanks for organizing the session and talking about equity. As during the keynote address also we hear that if there are inequality and if there will be digital divide, then AI will going to amplify the inequality. Now, the answer is also in AI. If I say 3 or 4 key things, A stands for maybe accessibility, affordability, accountability, and I stands for inclusive design in terms of that. So yeah, I think one of the key aspect is to have accessible system which can work in hard to reach areas. Again, thanks for quoting some of the interventions during national COVID vaccination drive when we were designing CoVIN, and it was supposed to be utilized by 1.4 billion beneficiaries, including those who are living in hard to reach areas, which offline environment. Can they access? Can they register? Is there a mechanism to do that? That is the accessibility aspect. The second aspect is the affordability. Do every citizen, do every beneficiary, or even with respect to the healthcare workers, around 1 million ASHA workers and 200,000 ANMs, can they access these applications where we are planning to incorporate AI? So the designing aspect must be such that the affordability criteria is maintained, both with respect to the user interface, but also with respect to the digital literacy. And the inclusivity aspect, I think I can keep on talking about it, but I got a reality check when somebody said that you are catering 1.4 billion population through 1 million healthcare workers, and there are 22 kind of disabilities. Are you sure your applications like CoVIN, even UVIN can access if somebody is colorblind, if somebody is not able to view things properly, if there are some other issues, how can we make it inclusive? I can stop here.
Yeah, we'll come to the particular intervention a little later. Dr. Mona Duggal, you are the director of National Institute of research in digital health and data sciences. So your perspective about AI and health equity issues, please.
Hello. Yeah, thank you for the question. I think when we talk about health equity and digital divide, it's very important how we actually look at it and look at the problem. So some of the things will come from the field experience that we have actually had. The first was when we are actually looking at some of the solutions, we forget that we are very excited to bring in the solution, but we forget about the entire continuum. And we might just go into the field, and this has been the problem that we've been seeing. People are excited about a particular problem. They'll say, okay, we can screen cancer, we can screen this. But do you really have the entire continuum? It's just not that you screen the person and then you leave the person. You have to make sure that the entire referral system is in place. So equity is in the, of course, we all know that probably there are certain people who will have better understanding of technology, and there are people who will be having less. So, for example, the elderly, certainly they are technologically challenged. And then you have women, they will probably, like in the rural areas or in the slum areas, if it's in the family, most likely the man of the family will have the smartphone and everything. So we will have those kind of challenges. But even if you're able to do those things specifically, but ensure that you have the entire referral system. So for example, 2 or 3 studies that we have done in the field. One was the DR screening that we did. We are very successful in identifying referable DR in the field in a rural setting. There were like 60 people we identified. And to our surprise, when we went back to understand, like, okay, we referred them, we told them you can come to PGI, but we never had a retina specialist nearby. PGI was like 200 kilometers, and out of that, only one male person made it. And that person also never came back again because it was too far. It was not plausible for him to get back. Then, in fact, one of our physicians said, there's no point in telling the person if we do not have the entire referral. So equity is not only that aspect that you are saying. Second studies that we are doing is more on the health education. So one was around how you use the chatbots within the WhatsApp. It was a fairly successful implementation, but again, I think it required a lot of hand-holding, but we had to make sure whatever knowledge that was being given to them had to be structured and validated. I think we were one of the first few that we actually, the papers that came out was around vaccine hesitancy, and we had the chatbots integrated within the chatbot, within the WhatsApp. And any information that we had done was validated. But the reason it was successful was because the person who was actually leading it was a pediatrician. He was leading from the front, and he already had a buy-in. When we took the entire system into the real world, it failed because we did not have motivated frontline health workers. So you have to see like how you are actually implementing in those things. Last is like the pragmatic trial we did for the integration of the like some of the systems that we had done. We realized, although we say digital tools, simple counseling might be even better. Some of the things that we see may even not require the digital tools at that level, because what you require even for that equity, if you have certain things within that vicinity, if you do a good counseling, people will actually go. So we have to be very sure how we are going to be implementing at which level and how. It is just not because you have the digital tools and the AI, but where you do it, how you do it, and how you implement it, and all the continuum is there. So all those systems need to be in place.
Thank you, madam. Thank you. I think Abhimanyu covered on the innovation side and the scale side. I think you covered into the implementation plus the the component of evaluation that is critical. Thank you so much, Ms. Vinita. Madam, over to you from your experience on AI and health equity. How do you design the solutions that I adopted?
So I think very important inputs have just been mentioned. From the practical experience, I know this is, the best practices will come later, but it's very important to understand that when we are building AI models, especially for health and looking at health equity, who are we really going to design this for? So the element of co-design here is very important. Now, when I say who are we going to really be designing this for, are there data sets already included? Are the data sets of the vulnerable population, of the remote area populations, of the gender biases included in the AI tools that we are going to look at for designing? health equity. So that's the first important thing, the inclusive. Welcome. Inclusive design principles must include those data sets. I'll come to examples specifically later because I was involved in a very important initiative called the Edison Alliance for the World Economic Forum, which we implemented in Africa and India for resource constrained and vulnerable populations. And we reached our target, you'll be happy to know, 1 year before, because we were able to triage and get those data sets into technology platforms to impact health. The second thing is the deployment strategies. Mona and Abhimanyu have both spoken about it. Deployment strategies would actually mean, are we focusing on scalable but low cost implementation models that will be able to integrate AI tools? And this has to be combined with digital literacy programs. What's the point of giving high-flying platforms either to the frontline workers or to the populations when, as you said, Mona, most of the women are deprived of even using those? So can we use instead say simple 2G platforms and large-scale LLM models? Again, on this, it's very important for us to be able to understand that whether it's Africa, whether it's India, we need multilingual interfaces.
Yeah.
So are we already approaching the co-design with those interfaces, which are not just relevant for the frontline workers, but equally relevant for the people we are going to impact? And a very important point is, like in Edison Alliance, which I can come back to later, we had the real dashboard metrics which had incorporated AI. So we knew exactly how many footfalls were happening in the primary healthcare centers, how many women, because suddenly we realized 3 months into the model that more and more women were using these telemedicine centers. So we immediately put in an AI dashboard, AI empowered dashboard and chatbot to attract more women. So that the women started approaching these primary healthcare centers. We knew the needle was moving. Women were taking charge of their health. And when women take charge of their health, it's not just theirs, it's the whole family's health. So we were able to bring in more diagnostic tools for infant mortality, for vaccinations, for various other things to measure onco issues in women. And finally, my fourth point is, as soon as you start building an ecosystem, like I have done in past in Madhya Pradesh and Uttar Pradesh, even in Rwanda, I was a part when I was in Bharti Airtel of the telecom models that we were building for health. Is it can't be done by one stakeholder. So health provider, you need a telecom provider, you need the government, you need community engagement to bridge the digital divide, and you need monitoring. Where are the equitable metrics to monitor the AI impact, where we need research institutes like NIMS?
Thank you, madam. Thank you so much. Anurag sir, you were instrumental also in health AI strategy, and we
So
did. Over to you, sir.
I'll keep it simple. I think there are two ways. One is to use AI to explore the digital divide. So people who use AI on satellite images to look at the parts of India that don't light up at night are looking at poverty. You can use the data being generated through the Ayushman system and many others. Anywhere in the world, there will be an equivalent. Continuously use AI to explore those large data sets to understand the degree of the divide. And the second is, imagine your solutions for people suffering from the divide. And recently we are building a palliative care system, right? The typical example would be give a bot that somebody puts on a smartphone. But recognizing everything that was said so far, multilinguality, can you use AI on the recipient end of a simple phone call? The person picks up the phone, calls, speaks the language they want. The other side uses AI to pick up on their language, find the right bot, deploy it, use VoIP, and come back.
Yeah.
For the person experiencing the palliative care advice, and this we call PalliGPT, it's no difference from picking up the phone to call a healthcare service, except on the other end, you have a multilingual bot with proper local knowledge, proper local data, and we ran a demonstration where the person would even get advice on which place in your locality would service you with your insurance status and so on. So very contextual local things, and if you think of it and you are trying to benefit those people, it will occur.
Thank you, sir. Thank you. I think Project Bhashini also is.
So we were leveraging Project Bhashini basically on the back end.
Okay, sir. Okay.
And India is building the digital public goods
Okay.
required to do this so that the burden is not on the person building these appliances.
Understood.
And that's, I think, the best way of thinking of India's vision of DPGs and DPIs.
Yeah.
and then people using this free stuff that the government is providing to de-risk themselves in trying to build innovative solutions.
Absolutely. Ms. Nande, thank you so much. I know you were difficult, coming here, traffic, but thank you for making it. We'll hear your thoughts, and then before we go to the second set of thematic discussion, we need to have a group photo because she was missing. Because one of the mementos all the speakers are getting is the group photo as soon as this session gets over. So, over to you, Ms. Nandi.
Okay. Well, first of all, my apologies for coming late. I was held up in an immunization action group meeting with the Additional Secretary and Mission Director, Joint Secretary, and colleagues from the States. And you'll be pleased to know that prime on top of the list was equity.
Okay.
For children who are missing immunization, either zero-dose children or under-immunized children. Coming from UNICEF, I have to begin by saying that equity is one of, if not the most important things that we look for. Armed by the Convention of the Rights of the Child, no child should be left behind. Every child should have access to all social services, not just health. And beyond access, they should be quality services. And not to say a lot, I think all of the esteemed speakers have had a lot of important things to say. But I just want to say that I think AI is an opportunity on those two fronts, access and quality, because it presents a range of possibilities, predictive models, analytics, machine learning, and through that we can have a better understanding of who is being left behind and how to reach them. But also because of task simplification, it means that health workers can release some of their mental and emotional energy and spend more time looking after our clients, our patients, our children, our babies, and give quality care. So an immense opportunity at a patient level, also an immense opportunity at a population, at sustainable development level to accelerate achievement towards the sustainable development goals. Thank you.
Thank you so much. I think amazing from where you brought in AI's enabling power at individual level, family level, community, society, state, national, international level, with child-centric equity, normative discussions. Thank you so much. With the permission of the audience also, because I know you are listening to this very carefully, give us one break to take a photo and then we go to the theme 2. Is it okay? Yes. Okay, thanks. So come to the front.
Back we go.
Thank you so much. Now we go to the theme 2. First thematic area was AI for health equity. We understand that it is extremely critical. But the second thematic area is how to do this. So how do you bridge digital divide? What collaborations are needed? Can we go beyond sector, bring different sectors together, different actors together? So from your experience, would be great to hear. Maybe I will start with Anurag sir. Over to you, sir.
I think, how to do it is always about getting the right set of actors together. The funders, the executors, and the stakeholders in particularly who take it and scale it. And usually we break down because we don't put all three together when we envision a project. So things become pilots more than solutions. And if I had only one thing to say, I would say that imagine the final stakeholder, the person that you're going to scale it and the users who will benefit from it from the very beginning. Usually everything else, the interested academic, the funders will fall into place once you do that. Over from my side.
Thank you, sir. Vinita, madam, you were mentioning about the...
I'll just mention, in fact, two very successful partnerships that we had done with Edison Alliance. So imagine we had a telecom provider, I can't name them because they're out of business in India now, and a healthcare provider, that was Apollo, who worked together to improve broadband penetration, which is so critical when you talk of digital inclusion in healthcare. Unless you have the broadband penetration, which means you have low-cost telemedicine solutions that will reach the people you are targeting. And number two, for example, MasterCard. Now you will say, what has MasterCard got to do with health equity? It's an elite concept, but no. MasterCard actually did amazing work in Ethiopia. And they brought health solutions to community healthcare workers, which is so critical. People who are actually deploying equity in healthcare solutions to the most vulnerable population were the community healthcare workers who were empowered by the MasterCard healthcare tools. So there are many new innovative partnerships that are now being worked on. I'm seeing them personally between insurance companies, healthcare companies, government and telecom providers, and companies like MasterCard, which will bring in so much digital inclusion so that people who are, for example, using fintech tools can embed healthcare tools alongside with seamless insurance coming to them. So these are the kind of solutions which we have to think of out of box and come up with better healthcare tools that are AI monitored.
Really amazing. Interesting also is to know what triggered that collaboration. Any thoughts?
Yeah, so for example, when we started the Edison Alliance, we realized there were 3 areas which needed AI solutions. One was health, the other was financials, and the third was education. And you'll be surprised at that time, I was with Apollo and we took the lead in healthcare. And what triggered was that we realized that in places like Madhya Pradesh and some other states, I won't name them, despite all the advancement that telemedicine was making, it was simply not possible to reach those populations. Why? Because we were not having broadband. Yeah. We were not, also things like we were not having, solutions to charge batteries of cell phones. So imagine for those 2 basic reasons, and it was not really gender issue, it was these 2 technical issues that was stopping us from, getting the health on a broadband platform to reach these populations. Absolutely. We saw in Africa that already in Kenya, for example, e-money had made big waves. So we realized there was an e-highway. Why not use it for simple healthcare solutions and reach, with better vaccinations and SDG goals could be achieved. Wow. In Rwanda, which had made huge strides in many fintech and e-ways, we were able to piggyback ride with healthcare solutions. Amazing. So I think imagine if you could do this with education, with fintech, you could very well do this with health, because both education and fintech are where women and children are equally involved. Absolutely. So I think these are the solutions we can look at.
Thank you, madam. I think the reforms in health also needs the reforms in other sectors. I think this is the best example. Ms. Nande, if I may ask you to continue with the case studies, examples on intersectoral cooperation for equity in AI.
I mean, these are all excellent elements that have been raised by previous speakers. I think of the business case understanding that is critical before you even begin to think about where and how AI can be an enabler or facilitator. And then we have to think of those in public health, okay, who are specialized, professional associations, academia, different organizations, international, national, civil society, who are involved in public health. And then from a human-centered designs perspective, of course, we have to talk about the patient and communities. So those are beyond talking about the funders and talking about, the high level or high stakes organizations that will collaborate with. I think these are important people or elements to consider in collaboration.
Thank you. I think you really stressed upon the business case. Also, from the other dimension is how do you sustain if there's no business case? I think it's excellent, man. Thank you so much. Dr. Mona, your thoughts, please.
Hello. I think I agree with what most have said. And I'm actually surprised whenever we are in this field. Every day I almost feel like we probably missed out on that collaboration. Because I don't think there's any other, as at this point, the most intersectoral point where I feel it's like we're just the blocks. And health, I always think about it as an outcome. Rest, everything is generally, if you see, it is all intersectoral coordination if we have to bridge the digital divide. I'll just give from our own personal experience. Still, when I remember that when we were trying to screen for diabetic retinopathy, when we actually went into the field, there was no electricity. Like if we had electricity, it was because we had put in a generator from a project. And if there was a surge of electricity, we lost all the cameras. So then what I had to do is I went back to the company. We asked them, can you send your engineer? So the engineer was there till we had the study. So I think we just have to think through the things. If you simple, like a school teacher might be much there for the education part. So you have to think, because I'm always amazed at how actually the equity, and we have just, now everything has to be collaborative.
Yeah.
We cannot be talking in silos. If I do not talk to the person across the room, and I think like just if you look at this conference, we have agriculture, we have energy, we have everything. Everybody has come together for this conference.
Yeah.
We can think about data centers, but if we say, okay, environment is not a part of it, we have to think about it, because we all know that if you build big data centers, the carbon footprint is also going to grow.
Yeah, yeah.
So it's a cross collaboration across the ministries. And I was recently a jury on the nation building, and I think I was quite surprised. Everybody was talking about the health problems. Unfortunately, the health person was not there. So we had no participation from actually medical students.
Okay.
But everybody, they did a beautiful job. All the arts and the IITs and everything, they did a beautiful job how they would solve the problems, except the health person. But you can very well imagine how cross collaborative it is that they could think through our problems.
Yeah.
Probably they did a better job. I almost feel that I can just take it and implement it. But they did an excellent job. I think it is just so cross collaborative at this point.
Absolutely,
Yeah.
absolutely. I think you brought a very good case study about very critical. I really like the 2 points. One, where you spoke to an electrician, you spoke to a company because you went out of the comfort zone to get them on board. I think that was very important. And the second thing you covered is about data decarbonization, because we are talking one side about the huge data centers, but also we have a data which actually is increases the carbon footprints. Thank you, madam. Thank you so much. Abhimanyu, over to you.
Thank you. So I think most of the things we have already discussed. I am left with maybe 2-3 anecdotes which I can share, but broadly, we are talking about convergence, collaboration, and most importantly, co-creation. Some of the recent initiatives I can talk about is when we initiated UWIN platform after COVID, it is supposed to be used by 1 million healthcare worker. Typically, one ANM or ASHA worker use or manage 26 programs, and every program may have 1 or 2 applications running in parallel. And just imagine the burden of data entry. And I discussed with team and I discussed with ASHA workers and ANM that is it possible to maintain a good adherence rate in such scenario. Something which came out is to reduce the burden of data entry, the Bhashni and the AI-enabled voice to text, can we use that? With UNICC, with Amazon Web Services, we managed to come up with a voice to text API. So I understand that it is much beyond AI and much beyond, it's not just a technical but a governance issue. But then at least 40 to 50% the data entry burden can be reduced. And more importantly, with the co-creation approach to understand. So they need not to perform data entry, they just to speak that, okay, this is the name of the child, this is the details of the vaccination, this is the weight of the child, this is father's name, this is mother's name, and let the system do the data entry work for these 1 million healthcare workers. And similarly, when we are talking about the convergence and the collaboration, India is aiming for measles rubella elimination, though the goal is later, but then Ministry of Health is aiming for this year. And we are generating so much of data of MR1 and MR2 vaccination coverage. However, the outbreak data is coming from other data set, and the case reporting is also happening parallelly. And then there are other disease modeling patterns. And then came this AI modeling, that if all of us can come together and use outbreak prediction, then based on the burden of or the overdue of measles rubella vaccination, and extrapolating that data with the coverage and the outbreak and the case reporting and the disease burden modeling, like the migration and other stuff can be. This has came out well with respect to outbreak prediction, and this is giving healthcare workers an early warning system that, okay, let's try something else, because there is a prediction of outbreak based on these GIS based systems and AI based systems in place. So I think this collaboration, this convergence, and this co-creation has to be further strengthened when we are aiming to ensure equitable access to healthcare services and leaving no one behind. Thank you.
Thank you so much. If I have to summarize, it's difficult from all, but I picked up few words. One was innovation, implementation, integration, inclusivity, but most important, Anurag sir covered, was being independent. Develop your own models, consider diversity of the country and make it more inclusive. Amazing panel. Now I will open the floor for few questions. We will take 3 questions. When you ask a question, tell your name, organization you come from, and very specific question. Over to you.
Thank you so much. My name is Gaurav Jain. I lead. Thank you so much, panel. My name is Gaurav Jain. I lead AI and ML Machine Learning and Data Sciences group for Pfizer APAC region. And thank you so much for bringing the human equity into the picture. We, in terms of the responsible AI, and since AI has been my bread and butter, but we still have to think about responsible AI, and our safety net is the human in the loop. However, in the rural areas where we have a ASHA worker or a doctor who is oversighting about 100 or 200 or 500 people, they are often overburdened. And the problem is that when they are overburdened, are they mentally challenged enough that they can say that, no, this particular answer that is coming from AI, can they challenge that? My question here is that how can we ensure that we create these data governance framework so that these AI workers, how can we prevent these AI workers, how can we prevent these mainstream or the on the front line folks so that they are not overburdened by this, and they are not just simply accepting the answer because they are under-resourced.
Yes, sir. Mr. Jain, thank you so much. Abhimanyu, I think from your experience. That's it. Thank you.
Thank you so much for this wonderful question. I think that's where we have to think about. I think the data and the infrastructure is lying with the AI developers, but the accountability is with the public health stakeholders, including ASHA workers, ANMs, and the frontline workers. It's very important to ensure the data quality, and that should be a prerequisite before we even think about introducing AI, because AI will amplify, and if the data quality is not correct, then AI will going to amplify the system weaknesses, which is not the right thing to have. So to empower the last mile healthcare workers, we can think about the process of automation using AI, like how can it reduce the data entry burden, how can it improvise the data quality for them, and then there should be checks and balances to see that on the regular basis on the output indicators as well as the outcome indicators. So output indicators could be the adherence rate, the activity rate, the time of updating the data, and the quality of data which is coming in, which will lead to the outcome indicators of the uh, like the coverage data, the outbreak data, which will help our frontline workers to take decisions. But before that, 2 steps back, we need to have that checklist. But thanks for a very important question. Thank you.
Yes, ma'am.
So, actually, I've just written about this that, when you're building these sovereign AI models, what is very important, which also came out in our preparatory discussion, was trust. And trust is not a slogan, right? So trust is about so many things. What kind of data? I would also go and say something like, the clear liability, the public procurement methods. Also very important is the model transparency. And can I take a step further, and since these inputs might go into a white paper, can we build some constitutional red flags, where, especially for health equity, these are high risk use cases. So I think all these models need to be really worked on. If AI has to be scalable, trust has to be scalable.
Thank you. Thank you so much. We have time for one more question. I see here. Maybe a gender balance, one more. Well, I will definitely give you a chance, but one from, yeah, Deepthi, please.
Thank you, esteemed panel. Myself, Dr. Deepthi, and I'm Associate Director at Deloitte. Thanks, ma'am, for bringing the diverse culture where we are with a lot of, socio-economic lags which we have. Now, my point is, with AI, of course, we all know AI is here for stay. But based upon the field experience, like I'm doing or probably I'm working with, don't you think we are amplifying this urban rural gap or public private gap rather than simplifying the solution for that? Like ma'am elaborated the point, they are probably not user friendly for them. So, meaning how we can cater that problem?
Sure. I think work in progress, but Mona ma'am, over to you.
I think I totally agree with you. But at the same time, you have to agree that it is a technology. When mobile came, we also had that question. Slowly, I think, slowly we have caught up. So I know, like, at this point, I always think as like a Brownian movement, everybody is going in a lot of directions. And we are trying to find a method to it. So hopefully, I think what we do is generally, right now, we do not even have the guardrails yet. Do not have the evaluation frameworks. What we generally try to target is what is feasible. So once we have the use cases that are feasible, that are easy, and we have a handle on it, then we start taking the difficult problems. I think that is probably, it's right. Maybe rural and urban we are amplifying, but at the same time, I think government itself is also taking a lot of those like actions so that equity maintains. But that part, I think we have to wait for the right moment. As technology comes, it will be there, but slowly, I think as we catch up, I think COVID was a big equalizer. It was at one point, like government had to put in like internet at every place because education had to be delivered. I think because education had to be given at every stage, like consults came in for the hospitals. I think at that point, we really put the technology solutions in place. So I think there will be moments where those watershed moments are there, but then as we say, slowly everything will catch up. But you have to understand, we cannot like try to force technology at every point in that sense. We have to do it.
Thank you. Anyone would like to comment on that particular work in progress question? Okay, if there are not many questions, sir, I promised you, please ask one quick question, then we close in next 2 minutes.
Hi, I'm Tuhin, work for Portal Health. So my specific question is on the data privacy and data interop. We are talking about India scale. I'm very India specific question. If you want to really do something on a scale, and if that data is not interop, how do I, as a patient, on the continuum of care, how do I ensure that I get the best care and I have the ownership of the data? Essentially.
Thank you. Yeah, please.
So thank you for that question. I'm about 3 months old in India, very new, but I've come into the excitement and the ambition around the RCH portal, RCH being Reproductive and Child Health, which is owned by the government, supported by UNICEF, digital longitudinal health record system that has already been adopted, rolled out in about 25 states. The ambition is to take it across the whole of India, and with that have interoperability, because we know that there are different systems working across different states. With that have several add-ons which will enable, the digital analytics, enable the AI aspects of it. So I see that as being sort of a test case that the world will probably learn from. We've already had about 3 or 4 countries visit India just to learn from what has already been done. But maybe just to say that this is in action and this is the ambition of the government of India.
Thank you so much. Abhimanyu? Yes, you want like to. Yeah.
Thank you. Very quickly, just to add that adherence to Ayushman Bharat Digital Health Mission, specifically ABHA, and 3 directories which are in place. One is HFR, Healthcare Facility Registration, HPR, Healthcare Professional Registration, and the Ayushman Bharat Health Account, the unique health ID. Once all system, and that is very strongly taken up by Government of India, once all these processes will be in place, then interoperability will be much easier. That we have seen with RCH2U and Portion Tracker integration using the ABHA IDs. And that is the good, and specifically with respect to privacy, adherence to the recent DPDP Act is something which will make the end user, the beneficiary, very confident that the data is in safe hands for that. So
Thank you so much. Before we close, Ilona, would you like to comment a few?
Yes, I'd like to comment on one thing that we are always doing in our work in this field on digital and AI, and that is to actually try and put the element of generational equity into the equation, because we are very keen in everything that we do that this co-production, this co-creation, this co-design actually includes the next generation. It's got to include young people, and particularly working in and with low and middle income countries where some of the populations, over 60% are under 25, but they are not part of the decision making in their country, and they are not part of the vision of a digital health strategy. One of my colleagues is here, Tobias Silberzahn, and he has read how many? 87 digital health strategies, and in how many are young people mentioned? 43%. In 43%, and those are not necessarily the countries with the highest youth population. So I would urge that there are different components of equity also that we need to take into account, and that also India, as a very young country in so many ways, should make sure that decision making, that input is also ensured by young people, and of course both male and female. Thank you.
Thank you. Thank you so much. 30 seconds. Time starts now.
Thank you. Sensei Raj?
know the lessons learned, and thank you, Aruna, for bringing it up, the generation equity part of it. Now, since this is a very sensitive issue of generative generational equity in the generative AI and the SLMs that we are building, even in this country alone, how do you see the platforms, not only here but around the world, the driving system, the drivers behind the healthcare systems, the Western-driven systems when it comes to, whereas the genetic profiling is different when you come to the Asian side or any other conflict. How has this been taken into consideration? Number one, the subsection of that is how are we actually enabling systems that would bring the younger generation into it as well? This is if you could just.
Thank you.
Thank you very much.
What I request esteemed panel members is you can have that discussion after this because
If we comment on the record would also be great.
very restricted time zone we are having. But Ilona, if you would like to respond later, okay, they will respond today. Thank you so much. So thank you all the panel members. Now may I request our founder and Chancellor of NIMS University, Dr. Mona Dugal, to stay there. So formally this panel discussion is over. Thank you so much. We'll go ahead with the MOU between National Institute of Research in Digital Health and Data Science and NIMS University. Anurag sir, you be there, please.